Okay, my name is Dr. Eshamsul. I am the Associate Professor and Consultant Prosthodontist at the Department of Restorative Dentistry, Faculty of Dentistry, University of Malaya, Kuala Lumpur in Malaysia. And let's begin the journey. So here, let's start with the examination of the patient. The case is about a 24-year-old male, actually dental student, who was referred to me for the management of his missing maxillary incisors with implant-supported prosthesis, which he allegedly lost in a motorbike accident, which happened in November 2018. So in which he sustained fracture of the crown 1-3 and complex crown root fractures of 1-2, 1-1, 2-1, and 2-2. All his maxillary incisors were extracted as part of the management at the emergency department. So in the accident, he also sustained condylar fractures as well as the left parasymphysis fracture of the mandible, as well as the right distal femur fractures. So at the time of the presentation in my clinic in November 2019, a year after that, he appears to be fit and well with no other relevant medical history. He was a dental student at the time in the 4th year in my university, non-smoker with good oral hygiene. And what you can see here, the clinical photograph taken from the facial view, we can see that almost it's a good height of the soft tissue, although a slight deficiency on the left side. And also you can see the fracture of the crowns of 1-3. From the occlusal point of view, you can see some defects of the soft tissue, which is quite significant. And here, the OPG was taken. I don't have the OPG prior to implant, but this OPG was taken immediately after the fixations of the mandibular fractures in 2018, which shows all the maxillary incisors extracted. So let's begin with the treatment plan. Since the patients already confirmed to have the implant-supported prosthesis, the prosthetic-driven implant planning was then initiated. So for this particular case, I used the Archegate implant planning software to stitch the data from the scan of the models, as well as the CBCT data. And following that, the diagnostic mockup was created. And based on this diagnostic mockup, the prosthetic-driven or top-down approach was then planned. The advantage of using this Archegate implant planning software is in particular for multiple implants, I could also see the parallelisms of the implants, as well as the projected the angulations of each implant. So in this particular case, I plan to place 3 implants at the position of 1-2, 2-1, and 2-2. So it's very important to have the correct 3-dimensional positions for the support and stability of the peri-implant bone and the soft tissue, as well as for functional and aesthetic outcome. So also using the Archegate implant planning software, the 3-dimensional, the correct or the optimal 3-dimensional positions was then planned for each of the implants. So in terms of the apical coronal, the buccolingual, and also the mesodistal, and also between the 2 implants could also be visualized during the software. So based on the literature, for example, from Tanau, Sulaiman, that stated, so the implant has to be positioned apical-coronally about 3 to 4 millimeters from the platform of the implant to the future marginal pharyngeal margin, as well as the distance between the implant and the adjacent root, minimum 1.5 millimeters, and between the 2 implants, approximately 3 millimeters. All these parameters could be achieved in this case. As well as the facial bone thickness based on the Grunder and Spray, for example, and also based on the CBCT I was able to place the implant with 2 millimeters approximately of the facial bone thickness to follow the evidence from the Grundy et al. And also Spray et al. So next, following the implant placement, the surgical guide was fabricated based on the plan. So the surgery was then performed on the 5th of November 2019. First, a full mucoperiosteal flap was libated to expose the bone. And the second, you can see here in the top left, the surgical guide was then positioned to ensure fully sitting through the windows, and then followed by the initiations of the first osteotomy. You can see here in the third picture that the position of the implant at 1-3 is relatively quite close to the palatal wall. But this is the position that's going to be prosthetic driven for the screw retain implant supported prosthesis. So therefore, following that, fully guided implant placements was done for all of the 3 implants. You can see in the first picture here that parallel pins will also be placed to further ensure the parallelisms of the implant. And the protocol for guided, fully guided implant placement using the R2 drills and R2 guide was followed. And finally, where the thread of the implants was slightly exposed at the position of 1-2, and also over the crest, there's some concavity there, and also the facial sides, it was covered with synthetic bone. So in this case, I use ETOS without a membrane. And finally, followed by the primary closures using 509 sutures. And next, and the treatment sequence is the second stage surgery. Now, because of the pandemic that happened in 2020, and the patient was also busy with his studies, the second stage could only be performed in August 2021. So almost a year after the implant being placed. So here you can see again, full mucoperiosteal flap was raised to expose the implant, because implant was placed slightly subcrestal. It can then followed by the placement of healing abutment and the primary closures again. So here the picture is about, I would say, about 3 weeks after implant placement, good healing around the healing abutment, and about 3 months after the placement of the healing abutment. You can see a maturations of the soft tissue around the healing abutment. The periapical radiograph also confirmed the fully sitting of the healing abutment at the time of the healing abutment placement with good interproximal bone height. So next, after the second stage surgery, it was the time for the provisional fabrications. Now, because the emergence profile of the soft tissue was around the healing abutment, it's deemed not suitable for the final emergence profile. Therefore, the impression was taken. Here you can see the cast following the impressions using standard impression coping around the healing abutment. And here in the pictures number 2, you can see how the cast was modified in the lab to create the emergence profile. And finally, the information was then transferred to the implant-supported provisional bridge, which was fabricated using ProTem periacryl resin, and also using the titanium temporary abutment. And it was further refined in the clinics. So the implant-supported provisional bridge was then delivered in January 2022. I started with a partial thickness of flap. So the idea is that we want to push the flap further labially to further thicken the band of the keratinized tissue. and followed by the fully seating of the provisional bridge. So following that, you can see here in the pictures number 5, where the flag was then coronally positioned and stabilized using the modified sling sutures, using the connector as the anchor. And finally, I also performed the frenectomy, so that to reduce the labial pulling of the soft tissue. So here you can see the healing, approximately about 10 days. It's a bit earlier, but because we were rushing for the patients to get engaged. So this the review about 10 days. You can see the good mature formations of the keratinized tissue on the labial aspects of the implant and the pontic. And here, about 1 month later, the maturation of soft tissue. And following that, on the 25th of March, the impression coping was then taken. So in this photograph, in this slide, you can see the final the soft tissue following removal of the provisional bridge. You can see some formations of the papilla, as well as a good form and contour of the soft tissue. So the impression was then taken. Prior to the impression taking, I actually copied the emergence profile around the implant as well as the pontic using this technique. So first attach the provisional to the analogs, which then embedded in polyvinyl siloxane putty and light body to capture the emergence profile. And following that, the impression coping at slide number 3 was connected to the analog, and gradually the flowable composite was injected in incremental manners and light curing to prevent volumetric shrinkage. And finally, here you can see the assembly of the impression coping as well as the modified the composite resin to copy the emergence profile of the peri-implant tissue and the pontic were assembled back into the mouth to the implant. And following that, the intraoral periapical radiograph was taken to confirm the fully seatings of the coping. And immediately after that, the impression was taken using polyether Imprigam Pentasoft. And following a month after that, the final restoration was received from the lab. Yep, see the final restoration, the screw cement retained, final restorations. Here you can see the changes to the soft tissues at the time of the impression taking. This was the picture at the bottom, immediately prior to delivery of the final prosthesis. You can see further how beautiful the soft tissue has been formed around the provisionals with adequate, not only the height, but also the width. This is in agreement with Nozawa observations, and also David Farah Nato was published in 2019, that the width of the height and the width in the ratio of 1 to 1.5, although Farah Nato found a little bit smaller ratio, 1 to 1.2. Yeah, but from the pictures we can see there's a beautiful height as well as the width of the supracrestal implant mucosa. So the implant was then delivered on the 23rd of March. So here is about 3 months review. Yeah, you can see the soft tissue is already more matured and stable, although a little bit of the papilla I would wish to be there. But nevertheless, you can see the band of keratinized tissue is well formed, both stability as well as aesthetic. So now you can see the review, the soft tissue and the hard tissue both being and what aesthetic was also was established in this case. And the baseline radiograph also confirmed the stability of the crestal bone around the implant here. You can see the peak of the crestal bone is still there. Yeah, although it's only about 3 months post-loading. So here you can see the changes of soft tissue gradually from the time of pre-operative before implant placement, after the healing abutment placement, and finally after the delivery of the implant supported propagation restorations, which shows the optimum vertical height and horizontal width of soft tissue. And here, recently managed to bring the patient for 1 year review, so where the CBCT was taken. So you can see the sagittal view of the CBCT at all the 3 implants, which shows the adequate thickness of the facial bone. So together with the adequate soft tissue height and the width, I would say the outcome at 1 year review is extremely promising. And I'm sure for the long term to come, these parameters which was fulfilled will ensure the health and the stability of the peri-implant tissue, as has been shown by Zawa Linker-Vicious for the soft tissue thickness, and also for the spray and Brunder for the hard tissue, facial bone hard tissue thickness. So with that, I would like to conclude my presentations, and thank you to the judges, to everyone for the opportunity given. Thank you.